Good evening everyone. Myself Dr. Harender DAGAR from MGM Medical College, Kishanganj. Today I'll be presenting OSSN. First of all, what is OSSN? Ocular surface is defined as slowly progressive benign malignant and malignant epithelial lesion of the conjunctiva and cornea. Squamous carcinoma accounts about 40% of conjunctival tumor. OSSN most commonly start in the conjunctiva and extend across the limbus to the adjacent cornea. Basically, it starts from the conjunctiva and extending toward cornea. Risk factors include ultraviolet rays exposure, acquired immunodeficiency syndrome, xeroderma pigmentosa, human papilloma virus, especially 16 and 11. It has been recognized that squamous neoplasm occur both in the form of invasive and non-invasive types. In non-invasive, basically it is carcinoma in situ, and invasive basically squamous cell carcinoma, which later stage of non-invasive type. Morphologically, it is classified into 4 types: fleshy, gelatinous, leukoplakic, and papillomatous. Most common types is gelatinous. Then the presentation varies from benign, from foreign body sensation, redness, irritation, diminution of vision due to higher astigmatism or involvement of visual axis. The mainstay of treatment is complete surgical excision with 2 to 4 mm margins, clear margins. Now we will come on case report. A 55-year-old male presenting to the clinics with chief complaint of redness, foreign body sensation, and mass in the left eye associated with watering from last 1 month duration. The lesion was slowly progressive, associated with pain, redness, and appearance of tuft of vessels, mainly sentinel vessels without well-defined borders. There was no history of trauma, foreign body injury, and chemoradiation exposure, and significant weight loss to rule out any significant systemic disease history. No past history of diabetes mellitus, hypertension, TB, and other chronic illness. On examination, right eye were unremarkable with best corrected visual acuity 6/6. Left eye, a fleshy mass, vascularized, gelatinous, irregular mass extending from the limbus to the temporal aspect of the left bulbar conjunctiva, size of 6.5 to 4.5 mm. As we will now see, this is the ASOCT of the patient, left eye, which showing thickening of the epithelium layer, mainly involving the epithelium layer thickening. Now we will come on blood investigation. TLC is 8654 cells per micrometer cubic. Hemoglobin is 12.4 milligram per deciliter. Platelet counts is 2,43,000 cells per micrometer cubic. ESR is 12 mm per in first hour. Bleeding time and clotting time 2.2 minutes and 10 seconds and 3 minutes 20 seconds. RBS is 88 milligram per deciliter. Serum urea is 16 milligram per deciliter, and serum creatine 0.98 milligram per deciliter. These values, serum urea and creatine, we will do because we will put patient on 5-fluorouracil uracil, which is excreted through kidney. That's why we will check KFT. A presumptive diagnosis OSSN was made. Patient was started on eye drop 5-fluorouracil 1% 4 times a day for 1 week, followed by drug holiday of 3 weeks. On follow-up after 4 weeks, this is the figure shown. Follow-up after 4 weeks, vascularity was significantly reduced and swelling size was slightly reduced to 3.5 to 3 mm. This is the picture after 4 weeks. After 4 weeks, we will put again patient on 5-fluorouracil 1% 4 times on day for 1 week and follow by drug holiday of 3 weeks. On follow-up after 8 weeks, this is the figure. Vascularity was present and swelling size was completely, lesions was completely resolved and mild vascularity is there. Discussion. OSSN is rare pathological entity. These are mostly benign lesion having very rare risk of malignant transformation. It involves only basal epithelium layer or full thickness epithelium. Pizzarello and Jacobi classify conjunctival intraepithelial lesion and mild moderate severe dysplasia based on the extent of involvement. UVB light, which is an important risk factor of OSSN, cause lesion of the DNA damage and formation of pyrimidine dimers. Various studies shown the clear association between HPV and OSSN, particularly HPV 6 and 11, which form complex with the protein encoded by tumor suppressor gene in the host. The diagnosis of OSSN is mainly on histopathological finding. The treatment of choice is surgical excision. Presently, topical chemotherapy is preferred as it is inexpensive, simple, and reduces the risk of limbal cells deficiency. 5-fluorouracil, mitomycin C, and immunotherapy is used mainly. In these three, most common is 5-fluorouracil, then mitomycin C, then INF A12 to beta. 5-fluorouracil are specifically during S phase of cell cycle. Various study has been done regarding efficacy and safety of 5-fluorouracil, and it has been found it is highly recommended in OSSN nowadays prior to the surgical excision. In my case also, there is almost complete resolution of lesion with 5-fluorouracil, which confirm the highly efficacious of 5-fluorouracil in treatment of OSSN, as it has been found in various studies. Now we'll come on conclusion. OSSN lesion of the cornea and conjunctiva are uncommon but demand appropriate attention due to the potential for visual loss and systemic morbidity and mortality. Early diagnosis and treatment of OSSN is very necessary to prevent the progression of lesion from pre-invasive to invasive types. Newer modality of diagnosis allow non-invasive evaluation, which correlate well with the histopathological tissue diagnosis. 5-fluorouracil is highly effective and well tolerated as primary treatment for OSSN. Various studies show 82% of tumor responding complete to therapy, although in my patient also it is highly efficacious. These are my references. Thank you.
Yeah, well spoken. I have a few questions.
Yes,
how did you arrive at the diagnosis? Like, what was your differential diagnosis? You said the patient presented with a fleshy mass.
Yes.
Yes. So.
Sir, ma'am, mainly did is for we will think about pterygium, but in pterygium, ma'am, cornea involved more. In this case, cornea is not involving much. Open karna. That's why, ma'am, or ma'am, episcleritis. Ma'am, in episcleritis, superficial episcleral veins is involved. That's why we put phenylephrine, 2.5 or 5%. We will blanch the vessels and it will resolve. So that's not happening.
So why did you say it's an OSSN? Anything specifically you saw that like?
Yes, ma'am. This is the specific gelatinous type lesion, ma'am. That's why.
Anything more?
Yeah. The same question, I think. Normally, if it's well defined.
Yes, sir.
So you would need two things. One is a firm diagnosis.
Yes.
The second thing is management. So if it's a well-defined OSSN, surgical excision takes care of both.
Yes, sir.
And based on the degree of neoplasia, etc., you can do, for example, an option would be post-operative.
Histopath.
Mitomycin C, intraoperative, post-operative after healing of the wound.
Yes, sir.
So in this case, it's a presumed OSSN.
Yes, sir.
You cannot still.
Sir, it's confirmed only by sir histopaths.
Histopath. So I mean, in my practice, or I think in most people would, you yourself have mentioned in the discussion that surgical excision is the preferred.
But sir, nowadays we prefer chemotherapy because in this scenario, limbal stem deficiencies not occur, sir, in chemotherapy. That's why today nowadays we prefer chemotherapy. Sir.
No, but even in this case, we would not have so much of. I mean, you would excise the lesion.
No, sir.
So excision
is the mainstay.
Double freeze cryotherapy, alcohol epithelectomy, all these are aimed at removing the tumor cells.
Yes, sir.
They can recur. So that argument is certainly there that even after complete surgery or removal, you may have recurrence and you may use
chemotherapy
like mitomycin C, eye drops, etc.
Yes.
But without a diagnosis, I am not very sure. I mean, I don't practice too much of oncology, but if surgical excision and diagnosis both, in this case we still have a question mark.
Yes, sir.
Whether it was an infective condition which resolved, so that will not be harmed. I don't know.
No, same point. This is only I wanted to elaborate on that. No, you have spoken well, and yes, we have both the options, surgical and your chemotherapy.
Yes,
depending on the appearance, and as sir was saying, if it is well marked, excision is there, still we do excision, but the question of recurrence comes, then again we have to go for the chemotherapy. But even in your 5FU, you must be having What is the chances of recurrence once you stop the 5-FU?
5%, ma'am.
5%.
5%.
Any comparative study between recurrence after surgical excision and after chemo?
Yes, ma'am. There is one study will show in chemo only 5%. In surgical, it is mandatory to start chemo for 2 to 3 months. Otherwise, it recurs around 20%, ma'am. Around 19-20%.
Okay, thank you, doctor.